All right. All right. Good afternoon. Hi, everyone. This is Cara Dina Sale with the Community Technical Assistance Center at the Silver School of Social Works McSilver Institute. And I would like to welcome you to today's web-based training about obsessive compulsive disorder. What is it? And how can we help young people experiencing it with Dr. Timothy Rice? Obsessive compulsive disorder is a chronic, common, and long-lasting problem in which a person has reoccurring and uncontrollable thoughts or obsessions, inner behaviors, or compulsions that one feels the urge to repeat over and over. People experiencing OCD generally have difficulty controlling their thoughts or behaviors, even if they recognize them as excessive and they interfere with their daily functioning. Today, you're going to learn about all of the signs and symptoms of OCD amongst children, as well as the best practices for treatment. Before we get started, I just want to take a moment to orient everyone who hasn't been with us on our Zoom webinar system. Everyone will be muted. The only videos you'll see is the presenter and ourselves. But we do have our chat functioning, and we're going to be chatting to everyone, so you can communicate with each other via the chat, and we love to do the same. So please use your chat. And we're also going to have a Q&A portion at the end, which Dr. Timothy Rice will answer some questions, but we'd love to take your questions along the way. So Connor and myself will be capturing those, and we can bring them up at the end. For your best viewing experience, you can go to the top right corner and click View, and then click Side by Side :Speaker, and that will give you the best viewing experience for today's webinar. I just want to say thank you so much to Dr. Timothy Rice, who's presenting today. He is a psychiatrist, the chief of the Mount Sinai Health System's Child and Adolescent Inpatient Psychiatry Service. He's a board-certified child and adolescent and adult psychiatrist. He attained his bachelor's from Yale University and his medical degree from Columbia University's College of Physicians and Surgeons. He completed his internship, residency, and fellowship in child and adolescent psychiatry at the Icahn School of Medicine at Mount Sinai Hospital, where he was chief resident for the Child and Adolescent Program. Dr. Rice is also a graduate of Columbia University's Center for Psychoanalytic Training and Research in the Combined Child, Adolescent, and Adult Training Program. So you couldn't be learning today from anyone more experienced and with great deal of knowledge. So thank you again, and I'll pass it along to you, Dr. Rice, and we'll get started.
Great. I really want to thank the host for having me and all of you for being here. I'm excited about this hour. I hope we explore a lot together. Really want to make this very interactive. So let's make sure through the core of this, we do a lot of chatting. I want to hear about if you've worked with any youth experiencing OCD, and I really want to hear what you've done that seems the most helpful. At any time, I'm going to try to do my best to monitor the chat here. And I already see that one of you is maybe having a hard time hearing me. I'm going to do my best to speak loud and maybe pull this up a little bit closer. Sounds like maybe that worked. Great. So let's begin. What is OCD? It's obsessive compulsive disorder, which shows that it consists of obsessions, which are intrusive, repetitive, anxiety-inducing thoughts, coupled with compulsions, which are behaviors that are undertaken to resolve the anxieties. There's one other important way that people with OCD can take down anxiety, which is avoidance. And it's important to remember that the lives of people with OCD can very sadly become restricted, self-destructive, and developmentally held back. I'm going to begin with a vignette. This is a adolescent woman that I worked with named Julie. She was 17 years old. She had childhood onset OCD. She was extremely intelligent, really creative, but she barely graduated from high school. She was working 2 jobs, getting paid overtime, and yet almost a majority of the money she was earning was getting paid towards cabs. She had an intense fear that she was going to kill herself by jumping in front of a subway in the city. And on account of that, she couldn't go into any of the subway stations. The only way that she could travel was by taking these really expensive cabs, which if you live in the city and you're working, you know how quickly that money can go out the window when you're taking cabs all the time. So as a therapist, I felt terrible because every time that I would see her, I mean, this was pre-Zoom, she'd be spending quite a lot of money just by getting here in person. And I also felt terrible that, she had she was very likable. She was charming. She had a very good ability to sort of strike up a conversation socially. But because she didn't want to go out because it cost so much, she was basically getting homebound almost. And as it became more and more time to make decisions in terms of that sort of transition between late adolescence and into emerging adulthood, and it wasn't happening, she essentially became a failure to launch type kid. And because I'd worked with her from sort of early to mid adolescence, and I knew from her history and from those that the parents had given that she had really been like an early onset OCD case in her early childhood, she always kind of informs a lot about how I think about OCD and how I teach about OCD. And you may find already, or you found, or you will go on to find that your patients really inform how you think about the work you do, and how you want to take a stance in terms of addressing it. So how do we help Julie? We want to focus on helping her to gain relationships again by sort of unburdening her of the avoidance of not stepping in front of a subway station. We want to think about freeing up space for her to think about what her professional choices are, be it going to college, pursuing a job career that allows her to focus on one and be able to develop it, or just to be able to kind of take time to think about what area of work she wants to do, to consider whether to go to college, and also just to improve the relationship with her family, which had become very strained by her not being able to move forward. And all of these things are difficult to do if a bulk of the day is taken up by intrusive thoughts that are essentially making your life unable to think. We'll get into this later in the presentation, but one of the core treatments for OCD is exposure response prevention. And that entails helping the patient through exposures to face some of the fears and to teach them that those obsessions won't overwhelm them, they won't hurt them. So it was a very difficult experience with Julie of helping her slowly make progress of getting into the subways again. She would have to put her back up against the wall as the subway tracks would come by to sort of, avoid getting to that, edge of the tracks. But with time, she was able to get back and make use of the subways, and she could get around more, and she began, branching out, and she did quite well. So let's first dig into what are the obsessions and compulsions of OCD and better characterize them. I think a best way to sort of understand OCD in an organized way is to use the SI box. This is the Children's Yale Brown Obsessive Compulsive Scale. It's one of the most popular measures of symptom severity of childhood obsessive compulsive disorder. It's commonly used in research and academic settings, and it comprises three main parts: the symptom checklist, the target symptom list, and a severity rating. It's a great way for patients and for you too to familiarize yourself with the common obsessions and compulsions, and I think we should go through the main categories together. So these are contamination obsessions. You'll see by looking at the list, you can probably think from depictions in movies or, patients that you've worked with, you'll have some ideas like, yeah, dirt, germs, things like that. But by going through this, you'll recognize that there's quite a few other things you might not immediately think of, but it opens you to recognizing how broad ranging some of these can be. So we see here bodily waste and secretions, urine, feces, environmental contaminants, asbestos, radiation, toxic waste, household items like cleaners and solvents, animals, insects, sticky substances or residues. Then there's fears about getting ill because of these contaminants, or fears of others getting ill by spreading contaminants. And I have seen quite a lot of this with coronavirus or COVID. There's one, the fear of getting sick, but then there's also the fear of spreading it. I think that's, I found amongst the residents and the fellows, and even myself when we work, there's probably a bigger fear of passing things on to our patients or passing things on to our colleagues than, getting the virus. So I think it points out that everything exists someplace on a spectrum between severe impairment from kind of obsessional worries and then what's quite normal and can often guide us towards healthier ways of living, in the sense of trying to keep others protected and ourselves protected from same. Just looking at the comments, Michael Dugan says, would love to hear a bit about the overlap between concerns and anxieties around contaminants for those with OCD versus sensory anxieties of those on the autism spectrum. I think it's a really good question, right? So we could maybe consider the fact that, like, children with ASD, they don't like it when they feel something on their skin that isn't what they expect. They can get very agitated if they have like a little tag on the back of their shirt, or they might not like it if there's some kind of a film or sort of like, you put sunscreen lotion on your child with ASD and they get very touchy about that. I think it's a almost broader question about, like, are we using categorical models of pathology and saying that OCD and ASD are two totally separate phenomenon, or are we looking at it dimensionally, recognizing that they can be different, but that there's also overlap between the two in the sense of some shared genetic determinants, or the ways in which just stress can be exhibited or expressed in commonalities between individuals of different underlying characteristics. I tend to be more towards the latter, that I think everyone exists someplace on a spectrum. I'm sure that there are significant differences, but I have seen very much that if you think, an even more common one between ASD and OCD is the restricted repetitive behaviors of autism spectrum disorders and some of the rituals and compulsive behaviors that happen in OCD. And maybe if enough people are interested in hearing more about this towards the end of the presentation, we can kind of talk about this in more detail and unpack it. But I think it's a great thing to bring up for the group and to touch on now, because it does really hit with this contamination piece. Oh, you are most welcome, Mike. He just says, thanks for going through that. Real quickly, Julie Contreras says, I am a clinician in a mental health clinic that also work with children in foster care. My greatest difficulty at this time is working with a child who has POCD and autism, lots of sexual abuse and trauma history that is seen through conditioning behaviors. And I think that's really helpful to point out too, just thinking that, like, these things aren't all biologically determined, right? The environment plays such a role that everything is stress and diathesis. So you have your biological determinants that lead to a presentation. You also have the stress that goes on top of it that will then push the child over into having a symptomatic type response. And certainly children who've been through severe neglect or abuse, be it physical or sexual, are going to be at a much greater chance of having symptoms. Later in this presentation, I'm going to show a video clip of a child that suffered an injury. This child had a history of physical abuse, and you'll see some of the behaviors that come out in an interaction with his therapist that take on a sort of Tourettic compulsive type presentation. And we'll go to that. And then maybe the final question from Susan, and we'll move on. We'll have more time for questions after a few more slides. Is OCD hereditary? We all have less severe cases of OCD, but when it disrupts your daily life, it becomes an issue. Yeah, so there are definite hereditary components of OCD. If you look at all the disorders of psychiatry, it's not one of the highest bound in terms of biological underpinnings, meaning if you look at a disorder like ADHD, bipolar disorder, schizophrenia, they tend to have fairly high percentages accounted for purely by genetics. I think someplace on the order of 70% or up. I believe OCD is a bit less, but actually I should probably check that before saying it, to be honest. I think it's a little bit less, but nonetheless, there are, a pretty high percentage of it as just genetics. So in other words, you could look at twin studies. Let's say you have two identical twins and you raise them in separate homes. The chances of those two kids both having OCD, it's not going to be 100%, but it's also not going to be completely separated from each other, in which case it would be all environment. It's both a combination of what those kids' underlying genetics are and some of the stresses that they're raised in. All right, so let's move on. Thinking back to those contamination obsessions, what might be the compulsions that undo those contaminant obsessions? Cleaning compulsions, okay? Ritualized hand washing, showering, bathing, toothbrushing, grooming, cleaning of items like clothes or important objects, or then other measures to prevent or remove contact with contaminants. So I think what's like kind of funny, right, is like makes sense. You get something dirty and then you want to clean. You think about something you don't want and then you undo it. It's a pretty clear concordance between those two things, and start to think about that as we go through some of the other OCD type symptoms. Okay, now childhood OCD, think about kids developmentally, think about like the average 8-year-old boy that you might know, right? They're pretty messy. They're not like neat freaks, So they're not really usually presenting with contamination obsessions so often, and they're usually not presenting with cleaning compulsions. So what do you guys think might most be the most common childhood obsession? If you guys want to be brave and type something out in the chat, I'll give you 5 seconds to do so. Organizing toys, someone says. Controlling routines, very good. Washing hands. Monsters, I like that one. That's actually pretty close. In fact, that's the closest one yet. Video games, fear of leaving the house. That's a good one too. Order symmetry compulsions, cracking knuckles, video games, having things match, the dark, wearing certain outfits. This is great. You guys are doing great. It's good. Fear of losing parents is very good. Many of you guys touched on it. What it all falls into, it's called harm obsessions. And essentially, these are aggressive ideas. It's the fear that you might hurt yourself, that you might hurt someone else, that harm is going to come to you or to someone else, violent, horrific images, that you might blurt out some obscenity or insult someone, that you might do something embarrassing or act on these unwanted impulses like stab someone, steal something, or be responsible for some other horrible thing happening. And these things, by the way, can get like pretty magical. I had a patient that like, if he didn't do a certain little ritual, he was pretty sure that a plane was going to fall out of the sky and kill people. Well, how would you ever be responsible for that? I don't know, but it's going to happen. So it gets pretty far-fetched. What do you guys think might be the most common way to undo these harm obsessions? Meaning, what would be the compulsion that comes with this? Any sense to that? And maybe we'll do a little 5-minute boom, 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 boom kind of thing again. Avoidance. Oh, wait. Marilyn Taylor, checking. That's it. You got it. That was it. And it was the very first one. Good job, Marion Taylor. So what they do is they check. And let's see here. Look, actually, I gave you guys a little hint. Look at that, but I didn't even show it. The hint is in the title. They do checking compulsions. So they check locks, toys, school books, items. They check to see if things have been washed, dressed, and dressed, that they won't harm others. Okay, that's the most common one, that they didn't harm themselves, that nothing terrible happened, that they didn't make a mistake, and then things tied to somatic obsessions. So what's most common? Mom, am I okay? Are you all right? Is everything okay? Is dad mad at me? Mom, am I still all right with you? Blah, 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 whatever it is, okay? I had a girl who in session with her, she couldn't put down her cell phone because the whole time she had to be texting her mom, Mom, are you still okay? Mom, is everything all right at the house? Mom, is there a fire in the kitchen? Mom, did you check? Blah, 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 whatever it is. And so what we did, again, going back to that exposure scenario, we had to turn the phone off, and the phone would get off. She couldn't check, and her anxiety would go through the roof, and she would just be sitting there. I can't do this. I need to turn my phone back on. Please put the phone back on. It might sound really extreme, but we all kind of do this in life, right? Think about maybe when you were an adolescent and you were having like your first crush, right? Let's say maybe I don't know, maybe you guys didn't have cell phones back then. I'm kind of, I don't know, aging myself, I guess. But let's say you send a text message to someone you have a crush on and then they don't write back. You might start having thoughts like, oh, did I say the wrong thing? Right? Like, did I offend them? Was this the wrong thing? And until you get that text message back, it's kind of like you can't check in to see what the reaction was. This happens all the time, even today, right? Like, it's much nicer to talk with someone in a business meeting or to see someone face to face, because when you're doing it through email, you have no idea what the person's reaction is. And that's why people always say, let's just talk about this rather than do it that way, right? Let me go back a second because I realized that I skipped by when I jumped over to checking. I just wanted to say, returning to Julie to make it more clear for you guys, Julie's fear of jumping in front of the subway car, that was a harm obsession, right? She was worried that she was going to kill herself by jumping in front of the oncoming train. And then this tracked to these earlier harm obsessions that she had in her childhood. And I'm going to go to those in just a second. And they represented an established theme with her within a current developmental phase. I referenced this earlier about emerging adulthood, but essentially adolescents are trying to go through what Peter Bloss called the second separation individuation of late adolescence. So think about a toddler. The toddler has to move away from being an infant, depending on the primary caretaker, usually the mother, to be able to go off into the world and to explore. And there's a little bit of a process as the toddler comes to do that. Well, a late adolescent needs to be able to leave the home and go off in their own life. And it's very scary to do that. Sometimes people get stuck with it. And essentially, by developing this symptom around the subway, it solved for this patient the fear that was going on about that. If you can't take the subway, you never have to leave the house, right? But essentially, instead of having to face and work through that, this symptom gave her secondary gain of having an excuse why she had to not face it. Well, I'm just going to have to stay in the house because I'm really scared about the subway system. Sorry, mom and dad, this is the way it is. Okay. Separation anxiety disorder. I want to make the point that anxiety disorders blend together, in my opinion. These things are dimensional. Separation anxiety is not too different from harm obsessions with checking compulsions. A child does not want to be away from his mother. When a child is removed from his mother, he can't check to make sure that she's okay any longer. When he's removed, anxiety escalates and then it's resolved upon reunion, right? So it's the same model, essentially. It's a very common disorder of childhood. It really does blend with kind of, again, developmentally normal periods of some OCD type behavior. When it's functionally impairing and severe, then it becomes a disorder. Think about this scenario. Bedtime. Jimmy does not want to go to bed, but father knows that little Jimmy needs to sleep. Father takes Jimmy away from his video games and says, Jimmy, guess what, buddy? It's time for bed. The lights go off and out come the monsters. Someone in the chat said monsters. So when the lights are off, the alligator comes out from under the bed. The zombie comes out from the closet. think about these things is that this is Jimmy's frustration at his dad's very healthy and appropriate imposition of a limit, right? So dad knows that Jimmy needs to go to bed. He needs to get his sleep. If it was left to Jimmy, he doesn't have the ability or the executive functions this early in life to recognize he has to regulate his video game use. He would just stay up all night and then he'd be tired the next day and he couldn't do his learning in school. So dad appropriately comes and sets the law. Jimmy, as a boy would, wants to rebel against it. He gets really angry at his dad. He loves his dad, but he also, maybe part of him, wants to kill his dad in that moment. But because that's a really unacceptable wish to sort of feel that way, it's much safer for him to take it, push it out into the environment, and concretize it or embody it into these sort of monster-like figures. That way, he doesn't need to say, no, I'm the one that sort of has these murderous or kind of, creepy, violent thoughts. It's those things that are out there. And essentially, when they come out to, frighten him or, torment him, it's the punishment that he kind of feels that he deserves for having these bad feelings about dad. So this is just all to say that, like, there's a lot of meaning to these things. Certainly there's no evidence for any of this, but we can sometimes use theory to inform why certain kids have worsening of harm obsessions and, checking compulsions at certain times. We can also understand why certain things we do for children can be helpful, like a nightlight, right? So you put a nightlight in the kid's bedroom and it helps them be able to check. When the lights go off, they can't scan the environment anymore to make sure that those monsters aren't there. But if you have a nice, warm, little glowing thing that helps them be able to look, they'll know that they're going to be okay and hopefully be able to soothe themselves to get to sleep rather than have to struggle with it. When you do a child interview, whether or not you're thinking about OCD, if you're just screening for childhood anxiety, you can ask about a nightlight. And it's a really good way just to see overall how anxious the kid is. Most children will get to a point that they're no longer going to need it, and they'll be able to self-soothe and regulate their own worries without the sort of crutch of the nightlight at a certain point. And if that anxiety is severe, that might be a later point in time. Just wanted to point out that though we tend not to think about the meaning so much any longer, you can see it when we do associations between the obsession and the compulsion in terms of what goes together, okay? This is a factor analysis study by James Leckman, amazing researcher. This was published in the American Journal of Psychiatry in 2008. So no wonder, right? You have hoarding obsessions. The hoarding compulsions are what undoes that anxiety. I really need a hoard. Well, guess what? I'm going to hoard to basically get rid of that worry. Symmetry. Oh, I can't stand that things are all out of place. Well, guess what I'm going to do to undo it? I'm going to basically order things and I'm going to kind of repeat things until it's just right. And I'm going to sort of count and make sure I have all my ducks in a row. The aggressive, which is the harm obsessions, along with sexual obsessions and religious falls into it as well. They call forbidden thoughts. And then that goes with the checking that we just discussed. And then we also discussed how contamination loads with cleaning compulsions. Okay, so back to Julie. I just wanted to show you what some real childhood OCD looks like. This was pretty severe. So she had a thought that there was a demon from another dimension that lived in her swimming pool up in Westchester. And this was another developmental phase. Think about like a child around, early school age, late preschool. They're going through a developmental transition where they sort of feel like they're the center of the world and they're very powerful and kind of like they're almost omnipotent. So in this fantasy that she had, she thought that she was the only person in the world that could stop this demon from, usually it wanted to eat her dog. It was going to come out of the pool and snatch the dog and pull the dog back into the pool. So what Julie could do is she had developed this religion where if she could like repeat this like phrase, the demon would not come out of the pool. And the religious, kind of chant, it involved like a lot of symbols and equations. This was also developmental as she was learning her math. She increasingly integrated like a lot of numbers and basic calculations into how this did, and then she would repeat it and undo it and do kind of think about the Piagetian stages of translations of objects. She could learn how to do subtraction, and then she could add the numbers back up and get the number again. And this was sort of what she did to help herself soothe when she was scared that this thing was going to come out. So really sad, because quite a lot of time was spent on this, and quite a lot of discomfort and tension was sent on this. And again, thinking about avoidance, what the parents would usually do is they'd have to keep the blinds closed in this glass door that overlooked the pool to try to help her, but didn't always work. Okay, just to kind of finish this up, sexual obsessions. Often involving homosexuality or aggressive sexual behavior towards others. One of the fellows I supervise right now has a kid that's very worried that he's going to rape his sister, which has been really hard for the fellow, who gets very concerned about it. One thing to point out that I don't think I included anywhere in the slide set: patients with OCD very, very rarely act on their obsessions. Like going back to Julie, who was so scared she was going to jump in front of the subway and kill herself. Doesn't feel so good to have an outpatient running around with active thoughts of jumping in front of the subway, right? It's like, is this a suicide risk? But the truth is, relatively low risk in the scheme of things. Certainly make sure that you work in close touch with the team, but and certain things can make people act out some of their obsessions, but there's reasons for that. Maybe we can talk about towards the end. Hoarding is just collecting a bunch of stuff, or feeling the need. The obsession is like the need to gather belongings. And then magical thoughts and superstitious obsessions, lucky numbers and words and such. Okay, I've been kind of neglecting the chat, guys. I apologize. I'm gonna quickly skim through. Let's see. Jen Tranquil said, since you said some of these diagnoses symptoms blend together, it's appropriate to use OCD interventions to address similar behaviors seen in people with other anxiety disorders or autism. Yes, it is. A lot of these books, in fact, there's even a series of authors who developed this thing called unified theory, I think, or maybe it's unified. I don't know. I shouldn't have said that. I'm not sure exactly what it is. If someone knows the answer, they can put it in the text. But yeah, the CBT with exposure response prevention is not only for childhood OCD, but also many anxiety disorders. Similarly, let's see if I have a copy of it immediately in my view. I do. Coping Cat workbook. I don't think it's for OCD specifically. It's for childhood anxiety disorders. But this is a pretty common one that people use quite a lot. And it's got cartoons and pictures, and you work through it. Towards the end of this lecture, I'm going to go through 2 treatment manuals that are pretty commonly used with this. But a lot of the things can be used, not exclusively. And again, we'll get to this, but like very rarely do you see a kid with only OCD. There's all kinds of comorbidities, and they all do kind of blend together, and we'll get into that. Shout out to Hal Marcus, who says Febreze or Glade makes good monster elimination spray. I like that. And shout out to Julie, who says thanks for the tip. I agree. Weighted blankets for adolescents is pointed out as like soothing things. Absolutely. medication can be so overused, right? Doing these things that are just comforting and like changing the environment for the kids, like really helpful. Rebecca asked why homosexuality and the sexual obsessions. I think it's because conservatively, historically, there is a big prohibition against it, right? Times have changed, fortunately. But many of the things remain with this sort of sense of like forbid, the look at the cluster, it's forbidden thoughts, and there still remains a sense that like culturally in the past that was forbidden. And obviously no longer is it that way, but it still persists. Interestingly, if you look at the religious obsessions, the frequency of that has really declined, and that's because over the decades, people don't seem to have as much impetus in religion any longer. And the truth is, I work on an inpatient unit with adolescents. You very rarely see adolescents with sexual obsessions around homosexuality any longer. I mean, it's very accepted. So keep in mind, when was the Cybox written or authored? I don't know, but it's already dated. Put it that way. Okay, let's move on to the compulsions. Where did I leave off? Oh my God. I don't know. I think we did the somatic obsessions maybe, and the religious obsessions maybe, but if we didn't, there it was. Oh, I wanted just to quickly do this miscellaneous obsessions. The need to know is a big one that's very prevalent, and the like sort of doing it just right is a very big one. I think also like intrusive images is important to know because kind of overlaps with PTSD. The person who mentioned the child with trauma, you can sometimes get like flashbacks that can kind of blend in with this, and that's sometimes an interesting sort of differential. Okay, here are the compulsions. So repeating, like rereading, like erasing, rewriting, repeating routines, like going up and down or in and out. By the way, that was one thing with like the whole thing with the pool demon, like she would go in and out, in and out, in and out of door sort of frames. Counting compulsions, sort of ordering and arranging, keeping, desks very neat. If you see my desk right now, it's not really an issue for me, I guess. Okay, hoarding and saving compulsions, having trouble throwing things away, saving little bits of paper, making excessive lists is often a common thing. Excessive games and superstitious beliefs in childhood, that's quite common, very unusual with adults. And then rituals involving other persons. This comes up quite a lot between children and their parents. It's sort of like forcing the parent to do something, and if they don't do it, the kid has a rage attack, and I'll talk about that in just a second. Briefly, Venetia points out, I never thought hoarding can relate to OCD. It's a pretty tight association. I don't have too much on hoarding in these slides set, but maybe, and I'm already noticing there's a lot of content to cover. Maybe in the future we'll do a part 2. It has been fun to teach with you guys. Okay, and then in the end, here are the miscellaneous compulsions. Rituals, needing to confess, eating behaviors. There's overlap with eating disorders. There's the list making I mentioned earlier. Touching, tapping, rubbing, that's like tics and Tourette's. We'll talk about that in a little bit. Doing things until it feels just right. Blinking, staring, that's also Tourettic. Trichotillomania, that's a disorder in itself, blends in. And then like self-damaging or self-mutilating behaviors. Okay, cool. So does any of this sound kind of familiar? I just wanted to stress out don't pathologize your family members, your friends, or yourselves. We all do this, especially under stress. It's only a disorder if it gets very, very rigid and very impairing. And believe me, I have many examples in my own life when I've done some of these things. Okay, what are some common co-occurring disorders of OCD? One presentation of importance is the ADHD, Tourette's disorder, OCD triad. I love this because it involves development, and I think that's the core of everything. It's hypothesized to be an inherited deficiency of impulse control with differential presentations by age. So if you think about ADHD, that onset's most commonly the earliest. It's like 6, 7, 8 years old at the very latest, right? And if you think about ADHD kids, they just do something. The impulse comes out. They grab the candy, or they run all over the place without really thinking about it. And that's because the brain at that age has the least development of the prefrontal cortex, the inhibitory areas. And so they just do. In Tourette's, that usually onsets a little bit later, like 8, 9, 10, 11. And there they have like what's called a premonitory urge, that they can kind of sense the impulse to do something, and they can inhibit it. Tics can be inhibited for a period of time until they give into it. And then that's when they actually do the motoric or the vocal tic. Then OCD onsets last. The most common age presentation range for OCD is like, 10, 11, 12, 13, sort of. And then everything becomes much more symbolized. So like think about, the harm obsessions in the example with little Johnny and going to bed. A lot of that aggression is sort of normal conflict with the father around bedtime. But everything becomes much more sort of abstract as the child develops and has the ability to make these things more symbolic. So here we go. Other disorders, the prevalence is 56% have separation anxiety. That's huge. Oppositional defiant disorder, more than half. Okay, so again, they can be pretty disruptive kids. Tourette's disorder, 25%, ADHD, more than half, 51%, and then depressive disorders, 39%. Okay, rage attacks. These are these explosive, angry outbursts that are grossly excessive and inappropriate to the situation and beyond the child's control. Way to think about this is avoidance, rather than thinking of the kids as like bad kids or rotting kids. They get stuck in like an obsessive loop. They get really nervous, and then to get away from it, they like, they just attack someone basically. And sadly, a lot of these kids get put on second generation antipsychotics, or they get, suspended or put in detention, or, they get really punished badly. And I think there's much more therapeutic ways to work with those kids. Okay, we're going to move on to treatment. We've mentioned CBT with exposure response prevention as the gold standard several times. I think it's also really important to do traditional care alongside that CBT. How would a CBD proceed? Okay, so you use your SciBox to create a symptom inventory. You make a therapeutic hierarchy, and then you work your way up. You measure through subjectives units of distress, or SUDs, and then you do these things called imaginal or classic exposures. You basically prevent escape, and I'll talk about that in a second. You assign homework, and then you do practice. You monitor progress, and you work your way up the hierarchy. And then you use your SciBox severity rating scale to see progress and show it with the family. And everyone says, oh my God, what a great job you did. And then, you're the best. Okay, so this is like a SUD thermometer. You want to bring this kid's anxiety from like a 0 up. You don't want to go all the way to 10 or even a 9 or an 8. You want to bring the kid's anxiety like a 6 or a 7 through these experiments you're going to do with the kid. And then you're going to have the kid sit with it. He's not going to do a compulsion to take the anxiety down. He's not going to run out the room and avoid the whole thing. You're just going to basically say, you're worried right now. That's your OCD, or many younger kids, you can call it like their OCD monster to externalize it. I had a little kid who, when he had OCD, his face would go, like that. So he decided to call it his lemon. So we'd say, "Ooh, your lemon is on you right now, isn't it?" He'd go. So that was cute. You have the kid practice with their parent at home, and that makes it very easy because essentially you're just coaching as they do it on the outside. Okay, so here's like an example of a scenario. This is a kid who's scared of germs in the bathroom. So you're going to make a hierarchy in terms of SUDs of like what would be the worst for this kid. So maybe looking at the bottom, the easiest thing is just going to school where there's a bathroom in the school. Then the next hardest thing is like maybe looking at the bathroom door. Then the next thing is like putting the hand on the bathroom door, then going in the bathroom, then sitting on the toilet seat. And then you take your hand and you like put it in the toilet water. That's the worst. Okay. So the idea is like the kid is going to freak out at the beginning if you have them even maybe start with like putting the hand on the bathroom door. They're like really, really phobic. So you might start at just like bringing the kid to the bathroom door and just having them look at it. And they're like, I got to wash my hands. I got to wash my hands. And you say like, listen, you're not going to wash your hands. You're feeling really nervous, but you're not going to die from this. Just sit with it. And essentially is the exposure concept. It's like kind of getting into like, on a hot day into a cold ocean. You put your toes in at first and it's like, oh, I can't do this. But then the more you just sit with it, your body kind of starts to tell you, I can do this. It actually feels really good. It's a relief to be in the ocean like this. And so you kind of, by gradually bringing the kids up that, you essentially help them overcome whatever the fear is. And then you kind of work your way through all the other symptoms that they have. Now, criticism of this is that the kids will just kind of substitute another symptom for whatever they've overcome. And I think that's a valid criticism of this type of approach. And that's why it's so important to complement this type of work with more traditional work. Briefly, I just wanted to say the difference between a classical exposure that's actually doing it in person or in vivo with an imaginal exposure where you make narratives. It's easier to do it this way with things that you're not actually going to do in real life, like have robbers kill your parents. You make a script and like, I would do tape recordings with like lightning noises and owl hooting and spooky sounds and talking about this, tap, tap, tap on the window. There's robbers outside and all this kind of stuff. So we can talk more about that. Okay. This is the March and Mule manual. If you guys are interested, you can get it used on Amazon for not too much. If you want to learn more about it, because that's about all I want to go into with the whole thing. And this is a family-based treatment manual, which is better for younger kids and is also, incorporates developmental stages in a nice way. You can incorporate it with your own style. Briefly, I just wanted to point out, you can integrate psychotherapy with medication approaches. POTS 1 in 2004 showed that Zoloft plus CBT was better than everything else. POTS 2, any reasonable med with CBT is better than anything else. And then POTS Junior was for little kids 5 to 8. That family CBT is better than just relaxation training and such. These are just medication options. They can be very complicated. Essentially, SSRIs are pretty safe, but they do have risks. Black box warning is a controversial topic. It's about the increased risk of suicidal thoughts. There's also augmentation strategies. I think I have like 2 more slides and I see some good questions I want to try to touch on before we end. SNRIs, just another approach that they might be less activating. Activating is when you start an SSRI and the kids get like a lot of action and a little bit animated, which can be difficult. Just wanted to point out that usually the outcomes, these things tend to persist. So I think it really underscores that like treatment relationships are very important. Short-term treatments help for fast relief, but long-term engagement in areas outside of just the surface symptoms are very, very important. Training in the clinical care, just as all of you guys are doing, is so wonderful and so important. A child with OCD is at the core of it a child. It's just a child with a disorder. And each child is very unique with their own story to tell. Our patients are our best teachers. I want to thank you for being here and listening to all of this. And I think with the remaining 5 minutes, let's do some questions and try to end on time. Okay, so thank you. Here's a question I just wanted to answer. Oh, here comes Kara, and I can hand it over to you. But someone just briefly mentioned PANDAS, and that is an important thing to bring up that I should have put in the slides. So PANDAS is like pediatric autoimmune something, I don't even really know. But the idea is that streptococcal infections and also like other things too, walking pneumonia can cause it. And there's a couple of other ones that have been explored. Can have an autoimmune reaction with the basal ganglia in the brain. That's the portion that manages motoric behaviors, but also the circuits that are thought to underlie compulsions, and therefore bring on OCD. So many people will say if you have an acute onset of OCD symptoms, you should do a strep test or a test for any of these other things to see if there's an infection there. And if so, treat with antibiotics. And some people will even say do plasmapheresis, meaning you hook up a central line and you clean out the blood for these antibodies. And, it gets very complicated. And it's a really controversial topic with some people saying there's great evidence for this. Some people saying it's not such great evidence. I will say, I don't think there's great evidence, but I've also seen several patients in my practice that definitely have the PANDAS association. I think it needs to be studied more. And I've seen kids with like acute onset eating disorders with PANDAS, with the OCD onsetting, and like the OCD was highly related with the eating disorder. Another kid who like had recurrent strep infections, and like treating with like long-term antibiotics was the way to really clean the whole problem up and stuff. So maybe enough on that, but it is a really interesting topic. Kara, is there any question you might like to see me answer or something that?
Yeah, I think we only have time for about one. We did get a handful, but this is just fantastic. Everybody's really loving it. And so, but I think there was a kind of a theme around, what are your thoughts about the connection between OCD and early attachment issues?
Yeah, good question. So I think attachment is the core of everything, right? Attachment is essentially how the child and the mother or father bond. When that bond goes poorly, there can be a real loss, a sense of self and relationships with others. And when that's not secure, all types of difficulties can arise, right? These categorical DSM diagnoses are sort of clusters of symptoms. They come, I think, essentially from the underlying problems in terms of how we relate to ourselves and how we relate to others. So if you look at sort of, I guess, like Mary Main's studies with the strange situation, some of Peter Fonagy's work might blend into it. I'm sure that they show that there are data that kids with insecure attachment have higher prevalences of anxiety disorders. I'm sure that exists. And OCD being pretty tightly combined with that, I'm sure there might be some data there too. I don't know it off the top of my head, but those of you that do parent infant work or work with kids with disorganized attachments in foster settings or other areas, keep up the good work, because I think that's so core and crucial as a way of addressing a wide range of pathology.
Yeah, agreed. Okay. Well, maybe we'll have to have you back. I mean, and there was some talk about hoarding, and this was just so fantastic. I don't think I'm sorry we don't have time for any other questions, but we do want to look at our upcoming events. We have Education Matters, a webinar series for family and youth peer advocates. Supporting students with mental health needs is first on February 2nd. Bullying emotional vulnerability is the second one on February 9th, and then functional behavioral assessments and behavioral intervention plans. So stay tuned for that. And then there is a new initiative happening at the New York State Psychiatric Institute, NYSPI, that they've developed on OCD. It's called Impact OCD. So you can find out more information here if you're curious about that. And I just want to again thank you, Dr. Rice, so much for your time and your energy and this wonderful presentation. And please fill out the evaluation if you can at the end, because we do listen to you. OCD was on the topics that you wanted. And so that's why we are having this webinar. So please fill that out. And I just hope everyone has a wonderful weekend and a wonderful Friday, and stay safe, and hope to see y'all soon. Any last words? Okay, take care, everyone. Bye-bye. Thank you.
Thank you.